Okay, great. So I'm going to be covering fires in the operating room and also event reporting. I have no disclosures. There's an estimated 200 to 650 cases of OR fires per year, small or large. This is extrapolated data that estimates about 1 per 200,000 cases. Most of these result in either no injury or very minor injury, but there are some cases that up to 20% will result in severe disablement or disfigurement. And even about 1 to 5 can cause a death each year. During this talk today, I'm going to review when they occur, why OR fires occur, how to prevent them, how to contain an OR fire if one does happen, and then event reporting. So when do OR fires occur? You can see on this chart here, about 21% are in the airway. So if it's a tracheostomy or a case like that, very high risk. Another 44% head, neck, or upper chest, which can also, I'll talk about a little bit later, have to do with the high oxygen environment. And then about 26% elsewhere in the patient, and another 8% can be within the patient, possibly an endoscopic case or laparoscopic case. And when we look at a study from the anesthesia literature that looked at claims, legal claims from 1985 to 2009, they reviewed 103 closed cases and found that 90% of the time the ignition was electrosurgery. 85%, similar to the data you saw on the page before, were head, neck, upper chest, airway type of cases, and 84% were open oxygen sources. So why do OR fires happen? Has anyone raised your hand if you've seen this before? The fire triangle. So I'll just go through this graphic and then I'll go through each one of these 3 parts of the triangle in a little more depth. But essentially we need 3 main things in order to have a fire in the OR. There's fuel, the oxidizer, and ignition sources. So fuel, there's not that much we can do about that, although we do have some choices. But the fuel is generally the patient themselves, the drapes, which are not coated with any sort of anti-flammable coating, as some people had heard in the past, they're not, and alcohol-based skin preps. Oxidizers have to do with the air itself, and then ignition sources, this could be the electrosurgery, as you saw on that slide before, that's about 90% of the time, but it could also be a fiber optic light source or laser. So again, the fuel, when we have a high enough concentration of oxygen, almost anything will burn. Specifically, though, one thing we can do is to be very aware of our alcohol-based preps, which are the most common preps that people are using. So there's a lower risk with a betadine prep. And making sure that that alcohol-based prep dries before you start. So you've got that 3-minute timer to make sure that it's effective, but you also want to make sure at the end of that that there's nothing like this, like with that big pool of orange. That's going to increase your risk of an OR fire. The fire can actually be hard to see when it's an alcohol-based prep. It can have very small blue flames, and so I'll go through some other techniques to try to avoid having a fire, but if it can occur, you may at first not even notice it until it becomes a huge problem. So that was the fuel. Then we have the oxidizers, oxygen, nitrous oxide, and where this comes into play is really with your briefing or your surgical timeout or pause. When you're talking with your whole OR team, the anesthesiologist, everyone in the room, you really want to think about your oxidizers in that moment. So when we talk about open oxygen, like a mask or a cannula, that's the time to think maybe you could use an LMA instead, something where you're controlling the amount of oxygen going into the room. You want to try your best to keep the oxygen concentration below 30% to minimize the risk. And in a case where you're specifically going to be opening up the airway, like a tracheostomy, it's best to use cold instruments to cut the tracheal rings and enter the airway. What you can see in this picture here is an ET tube, and the fire is just tracking right back up that tube because of that high oxygen concentration. And then ignition sources. We do have a lot of control over this part of the fire triangle. Electrosurgery, 70 to 90%. Other equipment, things like fiber optic light sources, as you see here, your laparoscopic light source, that can easily ignite a fire. So I'll go into some prevention techniques on a later slide, but you can imagine we can control where our electrosurgical devices are and how we're using them to try to minimize the risk of a fire. So I like to call these the always events as opposed to the never events. First of all, education of the entire OR staff. So fire drills, but also talking to the staff about fire prevention and some of the things I mentioned with the OR briefing. When you do your timeout, having a fire risk assessment. Does everyone in this room do a fire score or risk assessment during their timeout? Pretty much, you can raise your hands. I think it's becoming more and more common. And there's a variety of different scales. Some of them are more complicated than others. I know we do a pretty straightforward one, and it's both something that we do out loud, but also something that gets recorded in the medical record. It gives you an opportunity to review exactly what elements of the instruments that you're using are going to increase your risk. And then when we talk about electrosurgery as being an increased risk for these OR fires, we want to make sure to activate the instrument only when the tip is in view. Make sure that when we're moving the instrument out of our view, we've deactivated it, knowing where your foot pedals are at all times. Because if someone steps on the foot pedal, maybe in this case it might not cause a burn right away, but you could go on to ignite a fire if you don't know where that energy is going. And having your light source on standby before the case and then turning it off as soon as you're done with the laparoscopic portion of the case. In addition, you can also use wet sponges. This is especially helpful in an open case to try to decrease the risk of a fire. And placing your electrosurgical device in a holster whenever you're not using it so that it can't inadvertently be activated. Now, what to do if an OR fire does occur? So this is a pretty rare event. That's one of the reasons we talk about having fire drills with your OR staff, because since it's a rare event, thankfully, doing a simulation of it ahead of time can decrease the collateral damage once an OR fire has started. First, you want to stop the flow of airway gases to the patient, which is often disconnecting the breathing circuit. Now, if this is an airway fire, like a tracheostomy case, for example, you not only have to disconnect the breathing circuit, but you actually have to extubate the patient, and it's suggested that you would then pour saline into the airway. One strategy that people use is to keep a syringe of saline available for these airway cases, so in the event of a small spark, they can immediately apply that right away before they even get to the point of having an actual fire. You next want to assess whether you need to remove burning and burn materials from the patient. Anything that's significantly burning in any way, I have pictures in a moment, should be removed from the patient. There are very rare times when you could ever have a burning material and not remove it from the patient. And then extinguish the fire and burning material. So if you've taken the drape off, it's now on the floor, you could extinguish it in a variety of ways. It's pretty rare for the fire to be so large that you need to use a fire extinguisher, but there should be one in every OR, and you should know where that is in case you do need to use it. And then, of course, care for the patient, restoring breathing, addressing any damage or injuries. So this is an example of that extremely rare situation where you may be able to pat out this fire. That's your judgment call. I probably would just take the drapes off the patient and put them on the floor and not risk it. It's really, I think, probably not worth it to try to maintain your sterile field, which is really not sterile at this point anyway. More likely, you would just get the drapes off the patient. And in a disaster scenario, we use the RACE, an acronym that everyone uses, the rescue, alert, confine, evacuate that you're all familiar with from JACO. That still applies in the operating room. And in fact, alert should really be a step even when it's not a disaster scenario, just for any type of OR fire. You want to make sure that you're alerting other people to come help, but also so that other people in the OR suites know, not to roll a patient back to start another case when there's this event going on in another room. So now moving on to reporting events. So this is specifically not just for OR fire, but for anything that we've talked about today, any sort of medical device failure, whether it's electrosurgery related or not. We define this as any device that's used to diagnose, prevent, or treat disease or other conditions that fails to perform according to manufacturer's specification that can cause any death or injury. So device user facilities, like your hospital, have to report these to the FDA and the manufacturer. They are mandatory reporters. The facilities must also report any death or injury, so it doesn't have to just be a death. Any kind of injury or serious event or malfunction should be reported. This is the MAUD website. You can go to this and see this form anytime you want. On the FDA website, you just search for medical devices databases, and you get MAUD. And essentially, this is where all this information is entered so that there can be a tracking system to see if there's a pattern, and also just to know the total volume of injuries. The physician's role is not mandatory. We're voluntary reporters for this. I still would encourage people to be proactive if you have a device, whether it's electrosurgery failure or otherwise, to go onto the website and voluntarily report it, because otherwise we really don't know the nature of these failures. In addition, you should, of course, remove whatever's not functioning from the OR, sequester it with the original packaging so that you have lot numbers, retrieve any broken parts. Error codes, if it's an electronic device, should be recorded as well, lot numbers, and notify risk management, clinical engineering, and the manufacturer of any equipment that's not working properly. So this is just to show you what it looks like if you decide to do the voluntary reporting. It's not really a long process. There's just these steps you go through about the problem, the product, the device, and so on. Thank you.